Hey you guys, it's Nurse Desi. I'm back with another video. If you guys are new to my channel, let me introduce myself. My name is Destiny. I'm a 23-year-old registered nurse. I have been working in the ICU for a year now as of this month. And I just recently announced that I was accepted into CRNA school. So if you guys are interested in seeing nursing content, if you want to go back and look at my older videos, I did post content when I was in nursing school. And if you guys want to see my up and coming journey of becoming a CRNA, then like, comment, and subscribe and follow my journey, you guys. So it is February 5th and it is Wednesday. So today is the start of my 3-day work week. I am in the medical surgical ICU for anybody that's new to my channel, and I've been working night shift the whole time. I was also a patient care tech on my unit and I work night shift, so night shift is just my vibe. But I wanted to show you guys a week in the life of an ICU nurse and what I do on my work weeks, how I prepare myself and all that, because I'm also on a healthy life journey. So just learning how to eat healthy, working out, and just trying to balance that in my daily life, because I'm not gonna lie, being a night shift nurse, it is really hard to prioritize your health and your wellness. So some things that I do to make things a little bit easier for me is, first thing, I work 3 days in a row. I don't like doing on and off. Like, I know 3-day stretches are really hard, but it works out when you have your 4-day stretch and you can really prioritize your health. You can go to the gym all of those days. You can eat healthy and just like flip yourself back to a day schedule and live a normal life. That has been the best thing that I've been able to do when it comes to managing night shift. So that's what I suggest if you're going to be working night shift. So I always do mine in a row, and I usually stick to my same days. I usually do Wednesday, Thursday, Friday, because it gives me Saturday, Sunday, Monday, and Tuesday off. I love having the weekend off, and I also love having like my Monday and Tuesday off, because then it gives you time to run errands, go to appointments, and just do all the things that you like to do. So I feel like that has been the best schedule for me these past couple weeks. So I do that, and then I just recently got into meal prepping. So I'm going to show you guys what I prepped for my meals today and for the next 3 days, because I'm not gonna lie, I'm really not a fan of meal prepping because I hate eating food that has been in the refrigerator for more than 2 days. So what I've been doing is I only prep for 2-day stretches, and sometimes on my 3rd day I'll either try to prep something the day before, or if I don't have enough time to cook for that 3rd day, I'll just eat out that day, but I'll eat a healthy option. So I'll try to find something, but sometimes I use that as just like my cheat day, but not too crazy. I'll just try to get like, maybe some Chipotle or maybe a salad, Panera. I'll just find little ways to incorporate a healthy meal for that last day. But that's just, for my mental, it's better than me, because I don't know how people cook like 5 meals, because something about seeing like food in the refrigerator for that long and then the same meal, I get very disgusted and I just don't want to eat it. So I don't even want to waste money on prepping a whole bunch of food that I'm not going to eat. So I only prep food that I know I'm going to eat for the next like 2 days. So, and then I'm trying to figure out what is the best option when it comes to what time I should eat, because depending on my shift, I never know what type of shift I'm going to have in ICU. So I don't know if I'm going to be super busy and have a critical patient and I can't eat until like 3 a.m. Or I don't know if I'm going to be like very bored all shift, and then that on days like that makes me want to snack and just eat more and more. So what I'm thinking about doing, I'm thinking about eating my meal like right before I go into work, and then bringing like healthy snacks, protein bars, yogurt, and things like that to keep me through my shift, because I don't really get hungry at work because I'm so busy. So if I eat a heavy meal, a heavy protein meal before I go into work, I think that'll hold me over, and then I'll just eat breakfast at home. So that's what is my plan, because anytime I eat late at work anyway, I get very sleepy, very tired, and you don't want to be groggy and you still got to take care of like super sick patients at work. So I think light snacks will keep me up and moving and prevent me from getting too groggy, and also it'll make sure that I'm not holding on all that weight on me before I go to sleep, because trying to eat a big meal then go right to sleep, that weight will pound on you. So those are some of my little options that I'm going to be doing to eat healthy. So I'll show you guys my meal prep. And then also, y'all, for coffee, so I have been on TikTok, y'all. I've been watching all these little protein coffees. I have never been a protein shake fan, but I love coffee. And most of my videos, y'all know I usually go get Dunkin', I get a latte, and I never realized how many freaking calories are in that coffee. I will not be doing that no more. And I found an alternative. So I've been doing Premier protein shakes, and I've been doing 2 shots of Starbucks espresso. So I'm gonna stop by Starbucks. Y'all ignore my dog. He hears me about to leave. But I'm gonna stop by Starbucks, get me 2 shots of espresso. And 2 shots of espresso will have me on a go. Like, I will be at work doing everything. I will be like zooming up and down the hallways, like doing so much stuff. So I feel like that gives me enough energy that I need, and I'm getting my protein, and it's not as much calories as these Starbucks and these Dunkin' drinks. So that has been some things I've been doing. And I've been going to the gym. So my gym days are days that I'm off of work. So I'll probably try to vlog on a week that I'm off of work to show you guys what I'm doing when I'm off as a nurse. So if y'all interested in that content, then let me know. But I know a lot of my like nursing people and the people that are like in nursing school, they like to see what things I see in the ICU and how my shifts work and all that. So I think the work shifts vlogs are really exciting for most people. So I'm gonna do this vlog, and then if y'all want to see days when I'm off of work, let me know. So I will head out of work, and I will talk to you guys later. Okay, you guys, so I'm gonna show you guys what I'm bringing for my meal prep today. So first thing, I brought a fruit bowl. I have some cut apple slices and peanut butter, and then I got berries and some grapes. So my little fruit bowl is going to be when I'm snacking on night shift, and when I get hungry, I'm going to just munch on some fruit instead of going downstairs and getting chips and all the stuff that be in the break room. So I'm going to eat that as my little snack. And I'm probably not going to eat this all at once. So over night shift, depending on what type of night I'm having, if it's a slow night, I tend to snack more. So I'll probably like eat one snack, and then I put it up, and then a little bit later around like 2 or 3 a.m. I get hungry again. So I'll bring out my grapes or my berries. And then as far as lunch, so I made some fried tilapia, and a little overcooked, but I like my fish kind of fried hard, so ignore that. But I got broccoli and then also some potatoes. I will put a little bit of cheese on top, but I'll do that after I warm it up. And pretty much I'm shooting for a high protein meal. So all fishes like tilapia, salmon has a lot of protein in it. And in order to get more protein, I'm going to do a Premier protein shake, but I'm going to actually put this in coffee. So I'm going to do 2 shots of espresso and then pour this over. Y'all, it is so good, like so good. And then if I'm hungry again and I want a snack, I have a protein bar, and I really like these. These are the Ready Clean bars. Has 15 grams of protein and a good amount of fiber. So I really like eating these as chocolate if I want a sweet snack. And then I'm just bringing this like to eat on the way home. After night shift, I get really hungry, and I be wanting a big breakfast, but I can't eat a big breakfast and go straight to sleep. I'm gonna gain a lot of weight. So I'm gonna eat a yogurt, and then if I get really hungry, after I get home, I brought these protein cereal, and I'll eat some cereal. But I'm not gonna do heavy breakfasts. If I do anything like heavy, it'll just be some eggs to get more protein, but nothing heavier than that. And then I'll go to sleep, and then I got some more meal prep for tomorrow. So yeah. Guys, so I made it to work. I'm in the parking garage, so it's a little dark, but I got to work early, drinking my protein coffee. Y'all, it is so freaking good. I don't know why I'm just now finding out about this protein coffee, but it's giving me so much energy, and it tastes good. It tastes just like my latte. I don't know why I was not drinking this before. So since I'm at work early, I want to have a little chit chat with you guys. So I know I have a lot of new grad ICU nurses on my channel. And since your girl has graduated from her residency, I'm no longer a new grad anymore. I want to give you guys some tips of some things that helped me as a new grad being in the ICU. And number one is a good report sheet. So shout out to one of the experienced nurses on my unit. She gave me a copy of her report sheet that she actually got from another hospital, and she kind of like changed some things around and edited it to match up with our hospital and our patient population, and she gave me the report sheet, and I've been using it ever since I was a new nurse. And when I tell you, it is the perfect report sheet. I'm going to show you guys step by step of like how I give report as a nurse in the ICU, because a lot of people say our report in ICU can take a very long time because our patients are very sick. They have a long extensive history. We touch on all the body systems. Like in the ICU, we have to go through neuro all the way down to skin, GI, GU, CV, the respiratory status. So we have to go through everything. So yes, it can take a long time, but if you have a good report sheet and you're organized with the way that you give report, you will be in and out within 10-15 minutes at the max for both of your patients. So I'm gonna give you a breakdown of this report sheet and tell you guys how I give report and some tips of making this easier, because I think that was one of the most things that I struggled with, is that I would give report and I would be so jumbled up because sometimes so much things happen in your shift that you can't even figure out where to start, what to say, and you don't want to be holding up nurses because ICU is already busy, especially day shift. They be trying to hurry up and get their report so they can start their shift because they have so many more things to do than night shift. So I don't like dragging out reports. So I'm going to show you guys my report sheet and how I give report. Okay, you guys, so here is my report sheet. So it is a front and a back because, of course, y'all know these patients are very complex, so you're going to be writing down a lot, but I'm going to break it down pretty easy so that y'all can understand. So starting off at the top, this blank space right here is where the patient name will go. And if you have a patient sticker, then you can put a label right there, and that will help you identify what patient that you're talking about. And of course, the most important code status, room number. If your patient is a full code, that means that you're obligated to do everything. If the patient were to lose a pulse, if they're a DNR, then like that means if they were to lose a pulse, then we would allow them to pass, but we're still doing everything to treat the patient. But if they are comfort care, typically these patients will be like on a morphine drip or on some type of pain medication, and we are just allowing them to actively pass in peace and painless. The next box will be, of course, your patient's admission date, and this right here is what doctors are consulted on your patient. And depending on what issue your patient has, so if they're GI surgery, they're going to have GI consulted. If they're neuro, they're going to have neuro consulted. So that is where you will put the doctor's names and who all is consulted on your patient. And then right here will be isolation. So if your patient is C. diff, then of course they will be contact. If they are TB, they'll be airborne. If they have the flu, they'll probably be droplet. And then of course you will put what organism they have. So whether they have MRSA, C. diff, all that will go right here. And then of course, very important, allergies. You need to know these allergies, the patient's family members. So, and also contact number. So make sure that when you're in the ICU, sometimes a lot of people will be calling you asking for updates on a patient, but you need to verify that that family member is in the patient's chart and that they have like a code or can verify that this patient wants information given. So if your patient is up and awake and can talk to you, I always go and ask, hey, so-and-so is calling about an update. Is it okay if I give information to them? If they're awake and they say no, then do not give them information. But if they are like intubated, they're not aware, then you would probably need to establish a code so that you know if this patient is allowed to have, if this family member is allowed to have information on your patient. And then also admission weight. So weights are very important in the ICU because a lot of our medications are weight based. So if anything would ever happen to your patient, you also have to have a weight, because if you're about to intubate your patient, we use the weight to figure out what type of drugs we're going to give them and how much of what drug we're going to give them. So always know your admission weight and always verify that any drips that you have going matches with your admission weight, if that's your hospital's policy. And then right here, past history. So you will put down any past medical history that your patient has. So hypertension, CKD, CAD, anything your patient has, put that in the past medical history. And then once I figure out what this type of information, I flip over to the back and I begin to give report in this box right here. So all of this right here will be the patient's hospital course. So you'll put the date and then put what the patient came into the hospital for. So if they came in through the ER, through EMS. So for example, if the patient came in on 2/5, then you'll put 2/5. The patient came into the ER for nausea and vomiting, and then you'll also put throughout the whole hospital course of what has happened. So has the patient had any surgeries? Has the patient had any blood products given? Has the patient had any changes in status, mental status, anything like that? You'll put a whole layout. So you'll start off with the very beginning and work your way to the current date. And after that is when I will start with my assessment. So neuro-wise, you start off with temperature is important. So if your patient has had a fever, say, oh yeah, the patient has had a fever, or the patient is afebrile, you'll put that information there. Put the pupils, are the pupils equal, round, and reactive? And then also, is the patient alert and oriented ×4, or are they confused? Are they altered? Are they able to follow commands? So following commands means that if I go to a patient and say, can you squeeze my hand? Are they able to squeeze my hand? And are they able to understand like what I'm asking them? And then the RASC score. So the RASC is a score that we use to be able to see how sedated a patient is. So if a patient is on propofol, typically they're going to be like a RASC of -1 or -2, and that just means that they are sedated. But if we wake them up, they will be able to make eye contact with you. They'll be able to look at you. But if they're super like unresponsive, then they'll be a RASC of -5. And then if a patient was like very anxious, very agitated, then it means that there'll be a RASC of like +1, +2. So yeah, it's a score that we use to tell a patient's sedation level. And then also extremities. So can they move all extremities, or do they have any restrictions on an extremity? Are they like stroke patients may have a side where they are flaccid and they can't move that side, or paralyzed on one side. Or if a patient is a quadriplegic, then you'll put that they can't move their lower extremities, or whatever the case is, talk about that there. And then cardiovascular wise, so you'll say the patient's blood pressure, have they been hypotensive or have they been hypertensive? Have they been very labile, and what is their MAP goal? So that's very important. Are we keeping the MAP above 65? Are we keeping it above 60? All that will be in your orders. And then the rhythm. Is your patient in AFib? Are they in normal sinus rhythm? Are they in a flutter? Have they been sinus tach? Have they been Brady? That's very important, because if you come in and your patient has a change in rhythm, that's a very important thing that you need to try to figure out what's going on, and you need to get an EKG, assess if this patient is symptomatic or not, and see if you need to do any life-saving things. And then also pulses, edema, and then also as the patient has an A-line. So A-line is an arterial line, goes into the artery. It will tell us the patient's blood pressure, so you'll talk about that. And then all these are other hemodynamic monitoring things that we have. So if the patient has a Swan catheter that goes into their pulmonary artery, if a patient has a CVP, they'll typically have to have a central line. So all this is cardiac things that we monitor. And then access, very important. So, okay, does your patient have a peripheral IV? So 20 gauge in the right forearm, then you'll write that there. If they have a central line, quad central line in the IJ, you'll put that there. If they have a VAS cath, this is what they use to get any type of dialysis. And then you talk about the drips that the patient is on. So are they on propofol? Are they on fentanyl? Are they on any vasopressors? And you'll put what is each drip and what rate is it going at. And then sedation, of course, I talked about the RASC goal. And then I talked about for vasopressors, we need to have a MAP goal or a systolic blood pressure goal to titrate based off of. And pulmonary wise, so what type of things are your patient on? Are they on room air? Are they on any nasal cannula? Are they on Salter? Are they on high flow, BiPAP, or trach? Or are they on the ventilator? So a ventilator is very important. You need to know what number tube your patient has. So in case anything happens and your patient has to get re-intubated, that's very important. And like, you need to know what is the tube marked at their teeth, because that will tell you if the tube has migrated or moved out, and that will be important for them to know if they need to make any adjustments to how deep the tube is at. And then the mode that the ventilator is set is very important. The amount of FiO2 is the amount of oxygen that your patient has going. The amount of tidal volume is how much volume that they are breathing in with each breath. The PEEP is the amount of pressure that's keeping their lungs inflated. And then the rate, how fast they're breathing. So all this is very important. And then also if they have any chest tubes. What is the chest tubes at? Are they to water seal or are they to suction? And what type of output is in the chest tube? Is it bloody? Is it serosanguinous? Because if anything changes with the chest tube output, you have to notify the doctor. So that's important. And then GI. So first thing is AccuChecks. The patient's blood sugar. What has their blood sugars been running? Are they hypoglycemic or are they hyperglycemic? And are they getting insulin? And then also to suction. So if they have an NG tube or OG tube, sometimes we will put that to suction to see if the patient has any gastric contents that need to be, decompressed. So we'll talk about is to suction and what is the output, coming out. Is it bloody output? Is it bile? What does it look like? And then diet. So a lot of patients are either on TPN or tube feeding. So put what type of tube feeding they have going, the rate, and what is the goal rate. Because sometimes we will titrate the tube feedings up into their goal rate. And then also the bowel movement. That's very important. If a patient has not had a bowel movement in multiple days, then we need to do some type of bowel prep, put them on Miralax, something to help them poop. And then bile sounds, are they active, hypoactive, or not? So GU, this is important. So, does your patient have a Foley, or do they have a Purewick, or do they void on their own in like a urinal? What has their urine output been like? Very, very important. If your urine output is low and the patient has not had a low urine output, that can be signs of many things that is going on. So put every hour if they have a Foley, and if they don't, then make sure your bladder scanning them frequently to see if their bladder is full and they're just not able to void on their own. And then the color of their urine. And then anuric is if a patient does not void, or if they only void a small little bit. Typically these are like our HD patients that get dialysis. They usually don't make that much urine. And then are they on Lasix or albumin to help them pee? And then are they getting HD or CRRT? And that is our dialysis. So our hospital does run CRRT. So here's our CRRT numbers. And pretty much this is the type of solution that we are using for the dialysate. So to filter out their blood, depending on what the patient's labs look like, will be what solution they are on. And this is very important. So if a patient came in and their potassium was like 6, that means that they are hyperkalemic. Typically our nephrologist will put them on a 2K or 0K bag. That means that we are trying to rapidly bring down their potassium, and whatever solution the patient is on, their lab should start to try to normalize towards that number. So if a patient is on a 2K bag, we don't want the potassium to go all the way down to 2, but we want it to come down enough. And then as soon as it comes down to an okay range, then we will switch them typically over to a 4K bag so that their potassium will be right around 4, and that is a normal potassium. And then also we talk about the psychosocial. So is the patient, are they on 1013? Are they suicidal? Are they in restraints? And all that, or if they're just very anxious or have anything where it looks like they may be depressed, then we will talk about that in the psychosocial area. Next will be wounds and drains. So that's very important. If your patient has any wounds, so whether it's a sacral wound, abdominal wound, make sure that you tell how often we're changing dressings, because the wound care will put in orders and tell you how often they want you changing the wound. So if the patient has a sacral wound, then sometimes they may say every shift they want the wound changed. So make sure that you tell the offgoing nurse or the oncoming nurse what is the wound care orders, and make sure that if you see anything new, a pressure injury, pressure ulcer, put in a wound care consult and notify the wound care team and the provider. And then other and notes are just, if there's any other important information that you think that the nurse should know, write that right there. And then we flip over to the back. So right here is a checklist of things that we typically do. So of course, when you come in, get handoff from the nurse, then you would verify your alarms on your monitor. So if your patient's MAP goal is 65, make sure that you put in your monitor. If it goes below 65, it'll alarm so that you know that you need to get up and titrate your drugs. And also verify the patient's admission weight is being used for all of your drips. We talked about that. And then double check to make sure that the pumps are running at the right rate, because things do happen, mistakes happen. So you want to make sure that you are putting the right things down. And then also talk about labs, any overdue tasks. Make sure that you look over all your lines and your drains. Sign off on any high risk medications. So things like heparin, insulin, morphine, fentanyl, all these things are high risk meds that we sign off on. And then of course check your patient's lab work. And then we change our tubing on Tuesdays and Fridays, and our wound care day is on Monday and Thursday. And then all these are just checklists for documentation purposes. I won't go through all of this, but most important thing also will be labs. Make sure you go over your patient's lab work. So go up and check your labs, like your potassium, your magnesium. Make sure that they don't need any replacements. Your calcium, check that. And then any other, labs that you're trending. So are you trending a patient's, lactic acid? That's what we would do for septic patients. Are you trending troponins? Are you trending, anything that you're trending, tell the nurse so that they know that how frequent they need to be getting labs. And if there's any critical lab work, make sure you tell that to the offgoing nurse. And then last box right here is to-do list. So to-do list will be, what things do I have to do on my shift? So does the patient need to go to MRI, CT? Is there any pending procedures that need to be done on my shift? What are some things that have to be done? And write out your list and then try to check off all those things throughout your shift. So once we go through all this, we will go in there and see the patient and verify everything, and then you will start your day. So I know that seems a lot. It took me like 15 minutes to just go through this, and typically that's how long it would take on a very sick, critically ill patient. But I want to explain this to you guys. Any of y'all that are new grad nurses, it's important to have a sheet like this to help you give a report efficiently, and make sure that you're getting the important information out. So I will leave and go to work, and I will talk to you guys later. Guys, so I am dressed and ready for shift 2 out of 3. I forgot to come and talk to you guys after I get off of shift 1, because when I tell y'all, I was so fatigued. Like, something about being in ICU is that not only are you physically fatigued because you're like turning a lot of patients and moving everybody, but you're also mentally drained because you're critically thinking so hard about everything. And last night, both my patients, it was kind of crazy because both my patients had the exact same thing going on. Both my patients had pulmonary embolisms, and both of them were on heparin drips. Both of them were actively desatting, and then both of them were having like heart rate issues and blood pressure issues. I was like, what is going on? I was going crazy, y'all, because like I would walk out of one room, and then I always have my monitor set on my other patient, even if I'm in one room, so that way I can look at both of my patients' vital signs. Y'all, I will go in one room and then I will look up at my other patient and their vital signs will be out of order, and then I'll go in that room, fix what's going on in there, and then look back up and then my other patient got something going on. I'm like, oh my god. And it was an all night thing, y'all. Like, I could not sit down. It was bad. It was really bad. But on top of it, both my patients are going down to get procedures today. So I'm hoping everything went well, but I'm kind of hoping I don't get both of them back, because it's a little too much to have both patients with the exact same things. And then with heparin drips, the heparin has to be therapeutic, so you're constantly getting heparin assays, and then both of their heparins were not therapeutic. So I was constantly titrating on both heparins. It was just very tasky. So I'm kind of hoping like they give me one back and then switch me up with somebody else, because both of them were very busy and very heavy on just work, and it's hard to manage with just one person. So everything got done though. Like, that's one thing about me. I'm not walking out that building until everything is done. So I make sure all my stuff is done, patients are taken care of, patients are bathed, clean, everything is in order before I leave. But I'm praying for a good shift tonight. Hopefully it is not as busy as last night, but I did sleep really good, because when you get home from a busy shift and you're like mentally drained, you just want to cut off your brain and just throw it away. Like, that's how I was feeling. I just wanted to throw my whole brain away. So I slept great. I feel very rejuvenated for this shift. So let's pray that we have a good productive shift. So I will come and talk to you guys when I get off of shift 2 out of 3. Bye. Hey you guys. So I am at a shift 2 out of 3, and y'all, I wish I could tell y'all that it was a better shift, but no, it was actually worse. I don't know what has been going on our unit, but literally every patient on the unit is extremely sick and dying, like every single patient. So when all of the patients on the unit are literally crashing at the same time, it gets so chaotic, because everybody cannot be in the same room. So it is just a lot. Like, it's a lot, y'all. It's a lot. So I'll start from the beginning. So I told y'all last night I had 2 patients with the exact same thing. They both had pulmonary embolisms, and I told y'all I did not want that back, because they were both super sick and they were both like unstable, and it just wasn't a good assignment. But one of my patients ended up getting really, really sick and had to go down to the cath lab and get cannulated for ECMO. So the reason why is because when patients have a pulmonary embolism, it's very difficult for their lungs to oxygenate, because their blood is not being oxygenated, because there's a huge clot in the lungs, and all our blood has to go through our lungs in order to be oxygenated, sent up to our body. So when your body is not getting enough oxygen, you're going to eventually get very, very sick. So ECMO will help her, because ECMO can function as your lungs, and it can pretty much bypass the blood past her lungs and allow her lungs to heal and allow them to hopefully get rid of the clot. And then once she gets stabled out, then they will take her off of ECMO. So we do not take ECMO on our hospital, so we actually sent her to the CV ICU. So I only got left with one of my patients, and then I ended up getting a new second patient. Y'all, my new patient was so sick. Like, she had a bowel perforation, and anybody that knows anything about GI knows that bowel perforations get very bad very fast, because when you think about it, your colon is full of stool and bacteria. So if that were to burst open, your whole abdomen is going to be filled up with stool. And that means that eventually that bacteria that is in our stool is going to get into our bloodstream and cause you to be extremely septic and get very, very sick. So these patients go downhill very fast. But they took the patient to the OR, took out the whole colon, and then came and brought the patient to me. But at that point, the patient was already looking very septic, just looking very, very sick. So the patient was on multiple pressors, A-line, all the things, intubated, of course, very, very sick. But since my patient was sick, I'm in there trying to manage my patient. But then another patient on the unit had just came with a potassium of like 7. And if y'all know, hyperkalemia will kill you. High potassium is probably one of the most dangerous electrolytes, because it can kill you instantly. Potassium directly affects the heart. So when your potassium is high, you are going to have deadly arrhythmias like V-tach, V-fib, and then eventually Brady and asystole. So those patients get very, very sick also, and they cold very fast. So another nurse had the patient, and we started seeing that the patient's heart rate was going into V-fib. So of course we instantly had to go in there, help the nurse. We almost had to cold the patient, but we was able to correct the potassium very fast by doing hyperkalemia protocol. And for y'all don't know, how we get potassium down very fast in the ICU is it's a couple things that we do. So we have to give the patient calcium, because calcium helps protect the heart muscle, and then we give the patient D50 or D10, which is just some sugar water, and it helps prevent the patient's blood sugar from getting low, because we have to give them insulin in order to correct the potassium, because insulin causes potassium to shift back into your cells, and it will correct hyperkalemia, but only short term. That's the main thing. The hyperkalemia protocol is not a fix. It is only a short term thing that we can do until we can get to the fix. Because most patients, if you are hyperkalemic, meaning your potassium is high, 9 times out of 10 your kidneys are not functioning, because your kidneys will help excrete potassium. So if your kidneys are not functioning, that means you're in some type of renal failure, meaning you most likely will need some type of dialysis to correct your potassium long term. But initially we give the calcium, we give some D10, and then we give IV insulin to correct the potassium. And then there's also some other things that we can do, like bicarb. We can give albuterol treatments to correct potassium, and then we also can give some oral meds like K-Exolate to help you poop out potassium. So it's a lot of things that we can do, but long term the patient will most likely need HD or CRRT to function as their kidneys in order to continuously be able to correct their potassium, or it's going to go right back up. So that's what was happening with this patient. So we were having to help the nurse start up CRRT, because we do run our dialysis machines. But the thing is that starting up CRRT can take a while. So that's why you have to do the hyperkalemia protocol first, and then hurry up and try to get your patient started back on HD or some type of CRRT to correct it. So it was just a mess. And then to make it worse, we get another patient on the unit that had a huge pericardial effusion that was beginning to go into cardiac tamponade. Y'all, this was like straight out of nursing school. Like, when I tell you we had every type of diagnosis that you can think of going on the unit, and everybody was so sick. It was really, really bad. So the cardiac tamponade patient, we don't even normally get those patients because we're not CV or or the cardiac ICU, but we always end up getting patients like that. So with this patient, it was getting bad. Like, the patient was very tachycardic, had a narrow pulse pressure, just getting fatigue, chest pain, just all the symptoms of cardiac tamponade. So the only way to fix that is to drain the fluid off of the heart, and our doctors don't do that because our doctors specialize in the medical surgical ICU, not in cardiac. So of course he had to get the cardiac doctors to come over. So the whole unit was filled with cardiac doctors trying to do this bedside procedure to get the fluid off of the patient's heart. But yeah, it was so crazy because as soon as they drained the fluid off of the patient's heart, the heart rate instantly came down to normal. Blood pressure came back to normal because the patient's blood pressure was low, of course. So yeah, basically, if you have a large amount of fluid on your heart cannot fill appropriately. So your blood pressure is going to drop, and naturally your body is going to try to compensate by increasing your heart rate, trying to get more blood to your organs, but it's not going to be able to do it because it can't fill properly. So that is why cardiac tamponade can also be deadly. So it's just, it was so amazing to see that as soon as they drained the fluid off the patient's heart, everything came back to normal. And it just shows, like, I never believe that like patients are just like tachycardic for no reason. Normally a high heart rate is a indicator that something is going on, and it means normally that the body is trying to compensate for something else. So anytime I could walk in and I see my patient like heart rate above 120 or 130, 140s, I instantly start trying to investigate like what could be going on with this patient. Are they septic? Are they bleeding? Are they hypoxic? What is going on that's making their heart rate so high? And I always try to rule those things out before I just say, oh, this patient is just agitated. Like, I try to see, okay, let's treat pain. Let's try to treat anxiousness, anxiety. Let's treat all these things before we just assume that, oh, the patient is just anxious. Like, I like to figure out what's going on medically, and also, you know, it could be things that are going on emotionally that can also affect the patient's body. So it is just so amazing. Like, that's one thing I do like about the ICU is that you learn so much every single day, and it's really crazy. But your girl's at home. I'm about to go home, get in the bed, and do it all over again for shift 3 out of 3. So I'll talk to y'all later. Hey, you guys. So it is February 7th, and I am on the way to shift 3 out of 3. Y'all, thank God. It feels so good knowing that it's about to be your last shift and you're going to have a couple of days off, because when I tell you, this stretch has been so busy, and all the patients, I told you guys, all the patients are so sick that it's a lot. It's a lot. So I'm about to get me my protein coffee because I know I'm going to need it. I wasn't able to get it yesterday because I was kind of rushing. I was a little late, and I could tell I was drained because we literally almost had to code a patient at shift change at like 7 o'clock in the morning when we were already so tired and so drained. Like, it is just, y'all, it's a lot. It's a lot. Like, I had to drag the crash cart over there, put the Zol on the patient, like all the things. Thank God the patient didn't cold, but I don't know, it wasn't looking good. It wasn't looking good at all. So we are gonna pray for a good shift. Please let 3 out of 3 be decent so that we can enjoy our little couple of days off. And then on my couple of days off, I'm going to try to go to the gym because, y'all, I forgot to tell you, so I jumped on the scale because I just wanted to see if, like, eating healthier lunches at work made a difference. I lost 4 pounds, y'all. I really was so proud of myself because I have been consistent with bringing my lunch to work. So all the people that be like, it's hard to lose weight on night shift, it definitely is, but I feel like if you're intentional, you pack your lunch, you bring healthy snacks, don't eat too late, you can lose weight on night shift. You just have to make sure that you are meal prepping appropriately. And I do use MyFitnessPal, and I don't like fully track calories, but sometimes I'll log my meals just to see like how much calories it is, and occasionally I'll add up some stuff, but I'm not like faithfully every single day tracking calories. But I do think that helps to be conscious of how much you're eating and like proportioning your meals, because we be overeating a lot without even realizing that we're overeating. So those are some things that I've been doing, and I'm excited, y'all, because I have a little trip planned at the end of May, my little spring break trip, and then my birthday is in June. So I'm like, I need to be looking fit on my birthday and on my trip. So that's motivating me to get my butt in this gym and eat healthy. So yeah, I'm about to get to Starbucks, and I'll talk to you guys later.
Welcome to Starbucks. What can we start for you?
Hello, can I just get 2 shots of espresso over ice in a venti cup, please?
What else for you?
And that'll be all.
I see the window.
Thank you. I got my Starbucks. So 2 shots of espresso, Premier protein shake. Shake it up. Yeah, I promise you, it is so good, and it tastes literally just like a latte that you would get from Starbucks. So it's amazing. There we go. And then, ooh, that is so satisfying. Alrighty. And always ask for a venti cup so that you can put your shake inside. And trust me, you can also make this at home, but I ran out of the espresso that I like, so I've been just stopping at Starbucks. But I'm gonna go buy my espresso, and then I will do this at home, and you can save money. But 2 shots of espresso is literally only $2, so think about how much you're saving on your coffee order, because my original coffee order was like $7, and I was getting that every time I go to work. So there we go. We got our latte. Y'all, oh my gosh, it is so freaking good. So let's go ahead to work. Hey you guys, so I am at a shift 3 out of 3, and your girl actually had a really good shift last night, thank God, because I told y'all this stretch of shifts have been insane. I don't know what's been going on with our unit, but my patients last night behaved. Now the other patients on the unit did not behave, but my patients behaved. So I had 2 patients that were on the ventilator, and I told you my other patient, the sickest one, has a bowel perf, but I was able to wean the patient completely off of pressors. I was given a lot of blood products, but that does happen with like major gastric surgeries. Like a lot of times patients' hemoglobin does drop. So I was transfusing blood, platelets, but all of the blood products were able to allow the patient to come off of the vasopressor. So the patient looks like they're doing much better, and they're not appearing to be as septic as they were beforehand. So that is a win. Oh, and the patient started waking up and following commands. And I love that. When patients start to wake up on the ventilator and you're just like, squeeze my hand, and they finally wake up and squeeze your hand. It is just a good feeling. It's a good feeling to know, like, okay, the patient is awake, and as soon as we get the breathing tube out, they're going to be back to, normal. So that was good. And then my other patient who had the pulmonary embolism was doing good as well. So both of my patients did great. But y'all, the other patients on the unit, so we had a patient on the unit that decided that they wanted to self-extubate, which means that the patient pulled out their breathing tube. So the reason why this can be very dangerous is because when we intubate a patient, we are putting the breathing tube, past the vocal cords, but then we also inflate a cuff, and it's pretty much, it's like a balloon that sits in your throat, keeps it in place, and it prevents like aspiration and things like that. But when you pull that tube out and not properly take it out the right way, because if an RT takes out the tube the right way, they're going to put the balloon down, and then they're going to deflate the cuff, then pull it out. But if you pull it out and the cuff is fully inflated, you can cause damage to your airway. And the scary part about this patient is that this patient already had a known history of being a difficult airway. So a difficult airway could mean many things, but some things that can make a patient's airway difficult is if they have some type of swelling, airway swelling. So like, for example, if a patient is in anaphylactic shock, it's going to cause their throat to swell. And typically when patients are having breathing issues where we cannot properly oxygenate them or ventilate them, our next thing is to intubate. But the issue is that if a patient's airway is so swollen, even a breathing tube may not be able to go down. So that is when we get into some scary life or death type situations, because we can't put a breathing tube if your throat is swollen to the point where it is completely shut. So of course there's some things that we can do to help minimize the swelling, like epi, steroids, things like that. But it can be scary when you're in a process of like trying to intubate a patient, and then you find out that their whole throat is swole up. So this patient already had a history of being a difficult airway, and then they decided to pull their breathing tube out. But initially the patient didn't need to be re-intubated, because some patients pull their breathing tube out and they're actually stable. So their oxygen looks good, all the vitals look good, and if they don't need to immediately be re-intubated, we will hold off on it and see how the patient does. But overnight the patient became just hypoxic, and the crazy part about it is that the patient elected to be re-intubated, because the doctor came and talked to him and they were like, are you having trouble breathing? The patient was like, yes, I want to be intubated again. So if a patient tells you they want to get intubated, that's how you know things are serious. Like, the patient literally could not breathe, and we are not in this patient's body, so we don't know how hard it is for you to breathe. Even if your oxygen are saying that it's 100%, a patient can still be working very hard to breathe. But when you know a patient has like a really bad history where it can really be intubation, it's safest to call anesthesia. So they decided to call anesthesia, and y'all, since I'm actually about to go to CRNA school, I love watching anesthesia do their job. So of course I came in the room and I wanted to see the anesthesia's thought process and what they think when it comes to patients like this who has a difficult airway. And y'all, anesthesia is just such a great profession. I love anesthesia because they came in and they literally took over. Like, they saved the day, because this patient would have eventually crashed if he didn't come in and help. But anesthesia, they came in and then kind of talked through the process, and they felt like it would be safest to do an awake intubation. So I know that's pretty scary, because when we intubate patients, we naturally want to sedate them, because imagine a breathing tube going down your throat. Like, that is very traumatic. Nobody wants to be awake during that process. But the issue with that is that we first push a sedative, and then we push a paralytic. So when you push these medications, that can cause the patient to stop breathing, because we're paralyzing them and we're sedating them. So if you push these meds and then something happens where you cannot put the breathing tube down, what are you going to do? You're going to be stuck at a rough situation, because you can't oxygenate the patient, you can't ventilate them. Now, of course, there's other ways that we can do it. We can bag the patient. There's other things that we can do until we get the breathing tube down. But we will be in a tough situation if a patient is not able to be intubated after you've already pushed the drugs. And also, sometimes pushing the drugs to put patients to sleep can also cause them to have other effects, like cardiac effects, depending on what their EF is and things like that. So it's always good to stay on the side of caution when it comes to patients like that. So I was able to kind of hear the anesthesia's thought process and like how he feels like he would make this plan. So pretty much he decided that he was going to do a bronchoscopy, which is a camera that will go down and they can take a look at your airway and see what is going on in your throat before he put the glidoscope down and intubated the patient. So first he put the camera down. He did numb the patient's throat up with lidocaine and tried to make the patient as comfortable as possible, but the patient was still wide awake. So just imagine a whole camera going down your throat when you're wide awake. Like, it was traumatic. It was something I would never want to happen to me. But at the end of the day, if a patient can't breathe, it's like life or death. So you have to kind of weigh out the pros and the cons. So that was the safest plan that we could do. So they put down the camera. They saw that it was major swelling, but they got a smaller breathing tube than the typical normal breathing tube, and they were able to get the breathing tube into the patient. So and then as soon as we were able to successfully intubate the patient, we went ahead and pushed the meds to put the patient to sleep. And a lot of meds cause amnesia anyway, so the patient probably is not going to remember what happened, even though to all of us, we were all just like freaking out, because we're just like, oh my gosh, like, this patient is wide awake getting intubated, like, what is going on? But he said, like, the anesthesia provider said he hasn't done an awake intubation in a long time, but he felt like with this patient it was very high risk, and he felt like he needed to do that. And I agree, because the patient survived. The patient did fine. The patient was intubated and at least had a secure airway. So it was just very cool to see his whole thought process, how he assessed the situation, and he knew that it was bad. He had to call for backup. So the one thing about anesthesia that I realized is that it's such an intimidating profession, because you are at the head of the bed. So you are like, everybody is looking at you, and everybody is like trying to see what you're gonna do, especially if you're in a life or death situation. And it's kind of similar to like for me, like being a nurse, it's similar to like if something was happening with my patient and all the doctors start coming in the room and they're like asking you, like, you know, like, you're the primary nurse, like, what's going on? It's kind of similar to that, because you are the one that is like in the head of the situation, and everybody's looking at you to figure things out. So it can definitely get intimidating, but I feel like when you are confident and you are competent and you know what you're doing, you don't really fumble under pressure like that. So I feel the same way as a nurse. I don't fumble when I'm in critical situations because I know what to do. So like if you're in a situation where you just did not know what to do, then yeah, like that is when you will have to just call for backup. You'll have to get some help. But I really did like to see this because it just let me see like what career that I'm gonna be in, and it feels like I could tell it would be a very rewarding career to just help patients, because the patient wanted to be intubated. Like the patient was like, I cannot breathe, and it does feel good to be able to provide a life-saving procedure to a patient. Like it's kind of crazy. So that was my shift, though. It was a great shift, and your girl is finally off, and I'm about to enjoy my off days. But thank you guys for watching my vlog. If you guys want more ICU nursing content, then let me know, and I'll talk to you guys later.